And yeah, it's recording.
I'm struggling with how I'm going to advance slides. I guess I can do it that way. This is strange. I can't see the, I hope I'm not coming across as a Zoom dummy, but I'm having trouble. Oh, there it is. Okay. We have 14 participants. Outstanding. Just let me know when you think I should start, and I'll go ahead.
Sure. I guess we can begin now, and as they come in, I'll be able to allow them to join into the meeting. But yeah.
Okay, sounds like a plan. Hi everyone, I'm Dr. Michael Kanter, and I'm the chair of the Department of Clinical Science in the Kaiser Permanente School of Medicine. If people cannot hear me or are having trouble, I assume they'll just let us know in the chat room. Wanted to talk to you about how to achieve better outcomes for patients. So I'll be mentioning Kaiser Permanente a bit, but it's really focused on what I think is wrong with medical care and how it can be improved. And just to give you some background, I mentioned I'm chair of the Department of Clinical Science. Before taking this position, I was actually the executive vice president of the Permanente Federation and chief medical officer. So I oversaw the care, quality, and safety for the Kaiser Permanente system, which involves about 12 million patients and 22,000 doctors. And so all of their quality issues and concerns ultimately fold in under me. And I was doing that for about 15 years. And I think I've, over the years, accumulated some insights that I was hoping to share about, why our patient outcomes may be not as good as they could be, and some of the problems and issues before that. I've been with Kaiser Permanente for about 35 years. I have a background in systems engineering, which has influenced my thinking. And before that, and before actually during college, I was a cancer patient where I experienced dysfunctional systems of healthcare. And I can't complain too much because I'm still around and doing well. But I think it's important to look at the patient experience and what they actually go through to start thinking about how do you actually improve outcomes for patients. So keep all that in mind. The end game in healthcare is better outcomes for patients. And I'm going to kind of go through some of the problems and challenges with that. And so why is getting better outcomes hard? And the first thing I think we have to challenge ourselves with is, what is a good healthcare outcome? And there's a lot of stuff not measurable and not well defined. And then when we talk about healthcare and healthcare systems, I might add, well, what is a healthcare system and how do you define that? And I think there's a lot of debate in the national public domain about healthcare reform and healthcare coverage, but nobody actually defines what is healthcare and what impacts healthcare outcomes. Another big problem is fragmentation. Everybody takes a small element of care and does their best at it, but how do you put all of the pieces together to actually get an outcome measure? It's, the old joke of, the operation was a success, but the patient died. And so the surgeon did what he was, or she was supposed to do, but the patient didn't have a good outcome. And the last big problem is knowledge management, which is exciting to talk to students about because you're right now in the business of acquiring knowledge. But the real issue, and I don't want to shatter anyone's school experience here, isn't so much how much you learn in school, but how do you actually manage that and work with other people who have knowledge that you don't have? And how do you know when you don't know something? And how do you put this together in a system? And so I'm going to try and talk about each one of these things. Let's talk about what's a good healthcare outcome. And this is not my definition. The Institute of Medicine came up with 6 elements, or these elements of timely care, of good care rather. It should be safe, meaning there's no accidents, somebody doesn't say whoops and there's a bad outcome, no errors. Should be timely, which I think is self-explanatory, but we've all seen, the publicity the VA got with veterans waiting months and months for care. Should be effective, it should be equitable, and equitable is a huge issue with health disparities. And that is, people will have different care depending on race, ethnicity, socioeconomic status. There's many ways to slice that. Obese patients may get less good care than non-obese patients. All kinds of unfairness that needs to get addressed. Even if we got the average outcome better, we wouldn't be satisfied if it only impacted a certain subset of the population. I left off efficient, which really gets to the issue of costs. And there's all these debates about how much we spend on healthcare, and if we can fix something, but we have to spend 60% of the GDP to do it, is that good or not? And lastly, patient-centric, where patients need to be involved in the whole care process and deciding what works for them and what doesn't. So this is good healthcare, and as you can see, I'm giving you sort of broad frameworks, but if one wanted to quantify this and measure it in a more precise fashion, it's actually not very straightforward. And I think this has been hindering progress going forward, is figuring out how to measure these things and hold people accountable. I talked about reliability and safety, so we need to talk a little bit about systems. The old school thinking was medicine is a craft. You would go to medical school and then you'd follow a doctor around, and it's sort of the apprentice model. That's what started in the late 1800s. It continued on until really modern times, and I hate to say it, but this is the way most doctors are trained now. And it even starts, I think, as pre-meds. You're each individually learning and competing with each other. I think that still goes on. And then some of you get into medical school and you go through the same process for residency, and it's viewed that each person is an independent entity that tries to maximize their own skill and knowledge, and doesn't look at the system. And so if we look at other industries, and I like airline industries, it used to be pilots trained this way, and then they got smart and realized that they had too many plane crashes, and if they would start to form teams in the cockpit and systems and teams with the ground crew and the airplane manufacturers, and that any one of these people contributes, and if somebody fails, the chain is only as strong as the weakest link, and it's the system of flying, not the individual skill of the pilot, that determines safety. And so I'm a big fan of systems, and this is what I mean, and this is what you're already probably not learning in at least the typical pre-med system. Maybe your school is different, so I don't want to cast aspersions, but I think this is a societal problem, actually, that people aren't thinking about things right. when you look at a system, you can look at outcomes, which I've talked about, but there's also structures that need to be in place and processes that need to happen to get to the outcomes. So we don't always have to be looking at outcomes. But you may recall I talked about a system of healthcare and how we haven't defined that. And I think many people think the system of healthcare is the doctor's office, maybe the hospital, but there's so many more determinants of healthcare. It's been stated that health outcomes are maybe 10% attributable to the healthcare that people get, and 90% attributable what I call extrinsic factors that have to do with your education, your socioeconomic status, race, genetics gets thrown in there, what you eat, how much you exercise, all kinds of stuff, gun violence, all of these things impact health outcomes that aren't formally part of the healthcare system. And I would urge all of you to start thinking about how you would define where the system stops and starts, and not just think of the hospital and the doctor's office, but the whole red and blue together form the healthcare system. As you're solving problems in healthcare, you actually need to define what your system boundaries are. And I'll maybe stop there. I just wanted to point out, since I think we only have a moderate number of participants here, that I'm very happy if people go into the chat room and raise their hand. And my only ask is if Adam could somehow moderate the questions and look at things so I am not totally distracted seeing who's asking questions. But feel free to start a dialogue now rather than wait till I drone on for another 25 minutes or whatever I do, and then you're all sleeping and no one wants to ask questions anymore. But this is a really key concept that I think gets forgotten. And as we talk about a system, we need to talk about fragmentation within the system, because that is a huge, huge problem that isn't talked about enough. And we've got all kinds of politicians running around talking about healthcare reform, which to me isn't really reform. They're not changing the healthcare system. They're changing who's insured and how they're insured. But I haven't heard any of them talk about actually changing what goes on in the system, but merely providing more or less people coverage in what I think is a dysfunctional system. Those aren't necessarily inspiring words for the people pushing for the various healthcare reforms, but I really wish people would focus on how to make care better as well as more universal coverage, which I'm in favor of, but I just think that's a small piece of a bigger problem. And how do we get fragmentation? Again, it relates to how you start out, I think, as an undergrad, and you're all studying different subjects and different majors, and it's an individual sport. When you get into healthcare, you're actually part of a team. And so you have a large number of stakeholders, including the patient, the primary care doctor, specialists, nurses, pharmacy lab. You've got electronic records, and there's people that create and develop and maintain those, and huge controversies on how bad electronic medical records are for actually storing and manipulating information. You've got hospitals and operating rooms, and all of these entities and things interact to provide medical care. Just focusing on the individual doctor is a tiny piece of this thing. And in reality, there's actually many more people and systems in place, from people who clean hospital rooms and ORs to HR people and anybody that interacts with the system in any kind of way. And again, the system can be defined quite largely. I want to put in a plug for am one and was one that patients deliver most of the medical care in this country. They're the ones that take the medicine, do the treatments, do whatever the doctor says, some of the time at least. And the doctor, writes a prescription and says, do this, but that's really the easy part of the care. And self-care is huge. Adam, was that a question or just gesturing and moving around?
No, I have a question. The question was, since during your time as the main, as overseeing the quality of care for patients, how did you see, what were some of the difficulties you saw specifically with Kaiser Foundation and the Kaiser Permanente system, and how were you able to resolve that on such a large scale?
So large scale is, that's a great question. I could talk for 3 hours on that. I think the Kaiser system actually has a lot of strengths because it's less fragmented than most systems. So all the patient care and records is in one system. It's connected electronically. It's really easy to have one doctor look at all the labs and x-rays and doctor's notes. I mean, these things I sort of take for granted, but in most health systems, you go to a specialist, he has no idea what the 3 other doctors that saw the patient did. And so, and we can bring teams together to improve things. So if you're trying to improve infection rates in the OR, you can bring the nurses, the doctor, the pharmacists, the lab, all of these different people together, I think really easily. So those are the strengths of the system. I think it's still got some fragmentation. Size creates communication problems that, again, there's workarounds, but bigger is not always as nimble as 2 people sitting in a room saying, okay, now we're going to change what we do. So you have to get buy-in from large numbers of stakeholders to make changes. That probably one of the biggest problems, I think, is getting buy-in from independently trained people with different ideas and diverse opinions and all these specialists. It's the strength of the system, but also can be problematic when people don't see problems through the same lens. So to me, probably getting consensus and momentum around action is the hardest thing, but that's probably not unique to Kaiser either. A lot of this is size. Smaller systems can make decisions faster, but they don't have the systemness and the scale to actually have impact. So I'm not saying one's better than the other, they're just different. Knowledge management. I know you all think you're going to go to school, you'll get into medical school or dental school or wherever you go, and you'll be done with school and tests. You might be done with the tests, but not the school. Massive amounts of clinical knowledge, and once you graduate, you're just starting your learning. 40,000 clinical trials a year. I promise you no doctor reads all 40,000 of those trials. And so how do you manage things? And one of the challenges, does anyone know how long it takes from studies getting published to actually implement it in practice? And I guess I can't, if anyone wants to just shout out, that's fine. We've only got 30 people on the line, so I'm not too worried about mass shouting, but if I don't see anything soon, I'm going to give you the answer. And the answer is 17 years. So this is not a great system. I don't know if that surprises people or not, but it's because there's so much information published and trying to sort out what works from what doesn't. And even if a study is good, it doesn't mean it's implementable. And there's all sorts of barriers, but this is and this is one of the, to your question, one of the major problems. How do you implement new findings quickly? And getting it from 17 years down to 5 years, I think would be terrific, but it's still a long time. So, where am we here? Let's go into solutions. I don't want you to just think there's all these problems and there's not much to do about it. You have to start measuring outcomes and processes of care, and they have to be transparent. And this is a huge problem because not everything's measurable, but a lot of things are. And mortality rates and infection rates and cancer screening rates, all of these things can be measured. At Kaiser, we're pretty good about creating lots of measurements because we have a large integrated system and we can do this. Some systems can't measure a lot of things because the care is in different providers and they don't have access to the data. But once you can start to measure things and publish both internally and externally, you can actually start to improve things. If you don't even measure what you're doing, you can't. You have to define a system that you're going to work with. For Kaiser, it's straightforward because it's Kaiser's system. But sometimes we work with surrounding communities and other emergency rooms that see our patients and other systems that see our patients. Depends on the problem. But without thinking about what system you're working in, you don't get very far. Fragmentation, I'm going to talk a lot about, but anytime you can cut that, you make the system better. And you need a knowledge management system. I know you're all studying hard and learning as much as you can, and I don't want to imply it's an exercise in futility, but there's no way you're going to know everything. And so you need to start thinking about how do you manage the knowledge you and all of your colleagues are collecting together. And so let me talk about this interesting model, which we call the whiskey barrel. If you look at what you're doing is probably learning diseases and different items of care or different things separately. So these bars here vertically are different diseases or problems like asthma, and CAD is coronary artery disease and colon cancer. And this is how people learn medicine. As an undergrad, you learn your chemistry and your physics and your biochemistry. And I'm going to guess nobody actually puts it all together and says, this is how these things merge and work together. You learn separate stuff. So doctors learn separate stuff. And the challenge is when you deliver care, it's all fragmented. When in fact, there's many commonalities of colon cancer and chronic obstructive pulmonary disease. And as examples here, if you go across with these green bars here, they all involve some kind of medication management, which means you need a pharmacy system and a team of pharmacists and ways to decide which drugs to give and how to pay for them and what to do when patients don't pick them up in the pharmacy. These are all common to each disease. So you don't need to create the wheel for every disease. You can create commonality and apply it to everything. Similarly, health education is a huge problem. How do you teach patients? Remember I said they do most of the care. How do you actually teach patients? Having each doctor talk to each patient individually, not an efficient system, not an effective system. You can create health education systems and programs to educate 12 million patients on different diseases. So the idea is to take the fragmentation of each disease and create functions that are common to all diseases. And the physician of the future is really going to need to be thinking this way, designing systems this way. And it's a very different process than the old school Marcus Welby. I don't know if any of you know Marcus Welby, but the doctor that just goes from house to house and sees individual patients. is not something very workable now. As an example, how do you even contact patients? Most patients only go to the doctor twice a year, but they need ongoing care and things happen in between. So you can actually create a whole outreach structure that sends emails and voice phone messages and other reminders and virtual care without bringing patients into the office. This can be systematized across any disease. What do you do when you're in an office? I talked about outreaching to patients, but patients come into your office. Do you really think doctors can address all of the care elements in a single office visit? And the answer is they can, but they don't if you leave it up to individual memory and heroic effort on one person. No, if you create a system of care where care gaps are measured, monitored, and managed by the office team, it's very, very different. And we call that proactive office encounter. We've actually published on this system that I'm normally give a 2-hour lecture on. You're getting the 10-second version of it. But if you systemize the care, track by computer all the care that people need, put in systems to fill in those gaps, and the physician is overseeing that, but not directly doing all of the individual details, you actually can get most of this done. And in fact, I'm not going to talk about this other than to say that our rate of improvement was, based on some public measures, about 2 to 3 times as fast as the rest of the country over routine preventive care and health promotion, where we've estimated we've saved about 18,000 lives through different elements. You'll see here a lot of this is focused on health promotion and cancer screening and smoking cessation and hypertension control. And this is a lot of people. And again, it's thinking more systematically than individual patients. So key elements are think system-wide, think that patients aren't just in your office. They most of the time are regular people like yourselves, going to school, doing other things. And you can have electronic systems surveilling their healthcare needs as they interact with the system, which may or may not involve coming in for care. Complicated system, but this is, I think, where the future needs to go. I might point out, I don't know if any of you are interested in primary care. Primary care is not a specialty. I hate to break your bubble, but internal medicine, family medicine, peds are specialties that do primary care, but all doctors should do some. And this is our own internal data showing you that out of women who need a mammogram, only 38% of them are showing up in primary care, internal medicine, family medicine. The rest are going to specialty care. So if you go to medical school and become a dermatologist, you still need to think of yourself as a doctor and think about primary care. And in fact, our dermatologists and all our specialists will do a certain amount of primary care, which is how we got all of our screening rates and preventive care up so high. If you just rely on primary care doctors, it's not enough. That's not where the patients go. And that's part of the fragmentation I was talking about. Patients don't really care where their doctor trained. They want to go into an office and get their care needs met. And if they happen to be at a specialist, they should still get certain basic stuff done. I hope that's clear. It's an important point. Knowledge management, I just want to talk about. I think the typical model is you go to class, you cram to the final exam, you try and do better than the person next to you so you can get into medical school, and then you hopefully get in, or dental school or a pharmacy or wherever you're going. I'm being a little facetious and cynical here. That's not what you should be doing, but it's sort of the model of education of cram for an exam and then your knowledge decays. In fact, there's better ways to learn that we emphasize in our medical school that have to do with not cramming, but having stuff come back at you. Yeah, Adam, you have a
Yeah,
question?
and you think you could go into details about what Kaiser Permanente Medical School does differently? I think a lot of students have like been hearing about it. Like I've heard about it on YouTube and been seeing a lot of ads about Kaiser Permanente.
Okay, so that's a great question. We know that you forget if you cram. What you remember is what you repeatedly use to solve problems. So none of our classes are lecture. Students do pre-work, pre-reading, and then when they come to class, they're solving problems, often case-based discussions from day one, and they're seeing patients from about week 3. So the concept is when you learn your biochemistry and you learn what lactic acid does and how it gets derived, you start to solve problems with that knowledge, both in the classroom and in clinic as you see patients. And it's not just memorization of a bunch of facts, but working with the facts. And that I think is, I don't want to say we're the only school that does that, but we start quite early. But on top of that, when you design a medical system, our computer system generates a lot of decision support. So there's reminders and prompts for different elements of care, links to knowledge and databases that tell you information about diseases. We have knowledge that goes directly to patients through our patient portal. And we actually created a program that proactively scans literature and identifies articles where we think we may not have implemented a practice. A team gets on that and moves to implement. And we've probably put in about 35 or 40 new practices based on that one program. But in terms of the school, it really is what we're calling active learning, problem-based learning. And I'm hoping to get some of our students involved in the scanning of the medical literature and identifying new practices, because I think it'll teach them how to critically evaluate literature, how to decide whether what they read is generalizable to a specific system, and then how to implement the change. And so knowledge in itself isn't any good if you don't change how you practice. So we're going to be actively teaching that as well in something we call health systems science. So I hope that answered your question and made some sense. Makes sense to me, but so I'm going to sort of conclude the talk a little, and then I hope we can have some dialogue. But if we want to improve care, we've really got to think about systems engineering in healthcare and how to defragment health or fragment healthcare, integrate things, and remove unwarranted variation, create reliability, be patient-centric. Another big issue is making work actually satisfying. As you're all struggling to maybe get into medical school, there's a whole other problem of physician burnout, physician suicide. And I don't want to, for me, being a doctor is a great field. But if the work becomes overwhelming and frustrating, to me, it's not so much a volume of work, but a frustration of, if you want to provide good care and yet you can't because there's system barriers. That's where I think burnout enters into things. And we have programs at KP for the medical students to teach about positive psychology, resilience, but also how to work in a system. So when you are running into barriers, that you want to take good care of your patients, but you need to do X for the system. We're teaching students how to lead change within a system and make those kinds of improvements. Our whole vision for our medical students is to create the next generation of leaders and change agents, and more than just, we want excellent clinicians and they'll be trained to go anywhere and practice anywhere, but we also want them to carry some of the principles I've talked about outside to be able to really have a much larger impact on practice than just the few patients that may walk into their door. Next generation of students, if I were advising you, which I guess I am, that's not an if, you know, you got to recognize when what you're learning is fragmented and not integrated with other bodies of knowledge, and try and think about linking things together, think in a systems framework. If you go to medical school or other healthcare, don't become an ologist or a partialist instead of a, you know, partialist is my word for specialist, but you're first a doctor. This is really amazing to me, but if you ask any doctor, I don't care where you find them, you know, ask them what they do. They usually say, oh, I'm a dermatologist or whatever ologist they are. They rarely say I'm a physician or I'm a doctor. And so their whole identity gets focused on their specialty rather than being a physician first. I think that's actually key. And the other thing students need, I think, really work on is being proficient working in teams, which involves communication skills, certain amount of humility, and ability to get along with other people. And I know those sound like soft, fluffy skills, but there's actually a science behind it that we teach that you'll see in good functioning teams. We've actually done studies where we measured in the operating room the teamness of the operating room staff in terms of how they treated each other, and we were able to show that correlated to better patient outcomes if they had better teamwork. So it wasn't a function of the great surgeon in the room, it was a function of the great operating room team in the room. I think I will stop now. I can talk on any one of these subjects for at least an hour and a half if you want me to. I see some raised hands. So who wants to go first? Presley.
Oh, hi. Thank you so much for this great presentation. My question was about in your opinion, how do you think we could improve health information system in the United States?
That's a great question because there's so much whining and complaining about electronic medical records. I think first important to recognize they were designed to bill patients. I know that sounds ridiculous, but they are really good at capturing billable codes that insurance companies can send out and generate revenue. The fundamental flaw was the electronic vendors went to doctor groups and said, hey folks, why don't you help us design this thing? And doctors said, nah, we don't need electronic records. We're busy, we don't have time. And so the makers of these things kind of went off on their own, listened to other people, and designed billing systems. For the Kaiser Permanente system, that was particularly useless because a lot of our care is prepaid and capitated. And that's a whole nother subject. But so number one, they need to be designed for patient care. And the other problem with them is you can put a lot of data into them, but you can't retrieve it. Until we get really good at natural language processing and computers' ability to read free text, it looks in discrete data fields. And that's the most reliable data it gets. If you ask people how to put in data, it's a bunch of click boxes. And my concern is the patient narrative gets lost. Doctors are checking off boxes, this exam, that exam. They're not actually capturing the patient narrative, which means they're not listening to it, which creates all kinds of diagnostic errors and other problems. So I think if I were redesigning health records, I would sit down with a broad group of physicians, nurses, other health professionals, and ask them what they need and start building it from that point. Include the patients in this thing, by the way. And one good thing coming out is patients are getting better access to their own charts. And what that's showing is huge errors in the medical records where patients will go to the doctor, the visit gets recorded, and it's wrong. The history's wrong, the diagnosis is miscoded, all kinds. I've gone into my own record and my allergies were off and my meds were off. And so transparency of records, I think, is actually moving in the right direction, but that's another area we have to fix. So I hope I answered the question.
Oh yeah, thank you. It's just like, oh, what do you call it? I know people in my family in the healthcare field, right? And they always complain about charting and like, how long it takes them. And like, it's like, in addition to providing like the care, right? You're also like, focused on like, this huge charting part, which like, I guess they focus in some ways, they focus more on that than the patient care itself. So it's just like, I just wanted to hear about it, but thank you.
Yeah, no, that's absolutely right. And people will focus on what they have to, and they have to fill out the chart to get paid for billing.
Yeah.
And so the whole focus is wrong. I see Xavier Fields had her hand up, or his hand up.
Yeah, hi, Dr. Kanter. So I was able to read your biography on the Kaiser Permanente School of Medicine website, and I got to see a bunch of different things you helped out with and were able to accomplish. One thing I'm really interested in is identifying and hopefully reducing many health disparities within our health field. And one of the things I read that you were able to do was eliminate many health disparities among African Americans in the Medicare population. So I'm just curious about what those disparities included, as well as what strategies you were able to use to help eliminate them.
So great question. I'm glad you looked at. No, I'm particularly glad, not that you looked me up so much as the health disparities, because this was actually published in the Journal of the American Medical Association and Journal of Clinical Oncology, which are major journals read a lot. And I've been disappointed that you would think people would call me up and say, or call someone else in Kaiser up and say, gee, folks, how did you do that? Because we'd really like to fix it. And I've had two people over the years contact me, and I've gone to their institutions and given lectures. But it's really two things, and I could put it down to one. One is measuring to actually know what you're doing. So we measure a lot of our quality data by race, ethnicity, and can see if we've got a problem or not and try and address it. So that's key. But the other is just having a system of care. And so some of the stuff I described in 10 nanoseconds about systematically doing outreach, and if you're seeing African Americans not having blood pressure control, for example, we do outreach to people out of control, and we send them a notice saying, hey, your blood pressure is too high, you didn't pick up your medicine, come back in. That sounds actually kind of simple, but it's not usually done. And so I think having systematized care doesn't allow as easily unconscious bias and other biases to creep into the care. When you don't have a system, it's actually asking for extraneous factors to come in. If you've got a robust system that's designed to get everybody in control or compliance with a certain care element, it I believe mitigates disparities. And so the ones that I think I was referring to there that have been studied our cardiovascular care, mostly things like blood pressure control, cholesterol control, diabetes, as well as some of the cancer screenings, and colon cancer in particular was studied. So this system approach of sort of high reliability, I think works on certain things. I don't want to brag too much because it's got limits. And we tried it with flu vaccinations, and it was a miserable failure. And there's a lot of cultural reasons why different groups get vaccinated at different rates, that just having a robust system to make sure everyone's offered a vaccine at different times moved the dial a tiny bit, but not very much. So it helps with certain care, but not other cares. But I hope I answered your question. To me, this is a huge problem for the medical profession and society.
Yeah, I did answer the question. Thank you.
Nathalia, if I pronounced it right.
Yeah, it's Natalia, but Natalia is okay too. Hi, Dr. Kanter.
Okay, hi.
Thank you so much for coming today. I heard before from another doctor that some physicians over the years, because they have so many patients and they're always talking to those patients about different diseases, may somewhat lose some of their empathy and start treating that patient's disease as more of a problem and giving them more statistics than actually seeing them as a person. And I was wondering if you agree with this, and if so, like, do you have any advices for aspiring physicians or even other people in pre-health as well?
A great question. So I would agree with the statement that some physicians behave that way, but that's not the way they should behave. And it gets back to what I was talking about being patient-centric. And it's an interesting problem because you may be interested in controlling the patient's diabetes and getting their glucose within a certain level, and the patient may have a totally different agenda. And typically, you don't get very far unless the patient is engaged in their care. And gets back to my statement, patients actually do most of the care. I think if doctors would remember, they actually don't do a lot. They can prescribe, but there's actually studies, patients don't take their medication 50% of the time. So I think doctors sort of kid themselves that they're checking all the boxes and doing all of this stuff. But patients, if they don't trust the physician, they're not going to do anything. And so to me, this is all about communication and all about finding out what the patient's interested in, making sure, I talked about health education, but it's really people education, that people understand the ramifications of their choices they make, and putting in a lot of these systems in a way, the intent is to free up physician time so they're not focused on stuff that can be delegated to other members of the team, and they're focused on listening to the patient. It's easier said than done. This is the art of medicine. We do some measurements because we measure patient satisfaction and how well they think doctors communicate, but doctors who don't look at the patient are not good doctors. I've seen this, and I was talking about we got a lot of excitement when we started doing breast cancer screening in specialty clinics and found some breast cancers in our ophthalmology department. And our ophthalmologists like really jazzed, like, look what we did. Ophthalmologists don't normally pay attention to this, and patients really like a physician who is looking outside their little eyeball at the whole patient. And we've gotten tons of patient testimonials. I saw Dr. X, and he paid attention to something I wasn't expecting. So how you create that compassion, I think you have to have motivated physicians who go into it for the right reason, which is to help people take care of themselves and not to make money and have a lifestyle that's great. And I mean, doctors do well, and that's fine. I enjoy making money myself, but it shouldn't be the prime motivator. It's about the patient, and we screen carefully for that at Kaiser. Can we totally eliminate people that don't care about people? Maybe not. I think what's bad is some systems are so antagonistic toward medical students and doctors. They create people into cynics. And one of the things we have is called a REACH program, where about 3 times a year, students actually have time off to self-reflect with a coach and talk through some of these issues of burnout and getting desensitized to patients. And we're intentionally not only teaching these skills, but giving people time for self-reflection, which I think is key. And we'll hopefully in a few years have data showing that this program prevents the cynicism that creeps into medical education.
Thank you so much.
Okay, any other comments, questions? A lot of these problems start in medical school or earlier, and particularly this concept of getting sort of cynical with patients, that it's how we teach it. I even think the problem-solving learning will teach people to be curious and inquisitive, which to me are key attributes of a doctor. And the rote memorization of how much detail you can memorize about the Krebs cycle, I think breeds in a certain willingness to learn and do stuff that doesn't really help the patient, but is there for the test or the incentive or the doctor. And we're trying to teach people to be curious, inquisitive, patient-centered. And some of our small groups and our coaching and other stuff is designed to do all that. Other comments, concerns? Everyone's going to apply to the Kaiser Permanente school now. We really actually try, and all of our stuff is in small groups. So our classes, we not only don't have lectures, but it's within groups of 8 or 9 students with a single physician and biomedical scientist to really engage people and get people excited. And getting the clinical experience early has been our students have only been here like 4 months. We're brand new. It's really fun because it's a startup. And I feel like it's a startup. So they're just loving the clinical experience early on, and our doctors are loving seeing that enthusiasm in the students.
Oh, I had a question. Can you about the application process? Can you talk about more of what they look for when you apply over? What are some tips we could use to better
Well, if you listen to what I said, you'll probably get a sense of the kind of person we're looking for. Obviously, we look at test scores, and I can't keep track of whether the MCATs are being done now or not, but we look at that stuff, and we want strong students that can go through a rigorous curriculum, but we're really looking for people that have a passion and a drive and a mission to be leaders of future medical care and change agents. And how we ascertain that is part of the admissions committee secret sauce. But I think this is where people can convey that by what they've done, their experiences, essays, our interviews, our structured interviews, giving problem solving things during the interviews. So those are ways we assess it, but it is a sort of holistic admissions process. There's not a formula because we can't have a formula. I hope I answered the question. Adam, you had something else?
Thank you.
Thank you. Yeah, I just have one like add-on question for just undergraduates right now. I know a lot of medical schools have like these programs where undergraduate students can get involved with the medical school, although it's not related to like actually being in the medical school. So for example, like Hofstra has like the brain turns. Does Kaiser Permanente Medical School have like an equivalent program where undergraduates can get more involved in learning more about a certain sector of the
That's a great question. Well, we do have our pipeline programs, mostly geared to engage underrepresented minorities in recognizing their potential to become healthcare professionals. And we've got a fairly large system of that's based on what the HAPI organization at large has. So in terms of what I think you're asking about, do we engage with undergraduate students who want to work with us in some kind of way? I don't think we do. We're still starting up a lot of programs. So if you wanted to make a proposal between Kaiser and your institution, for example, I think that would be really interesting. But right now we actually don't, but it's a good idea. There's a lot of things we're starting up that I'm used to being a big organization, and I moved into the medical school, which is a separate legal entity from Kaiser Permanente. And I kind of like the startup mode. We change fast, we do things fast. There's not a lot of bureaucracy. And as students make suggestions, we're making changes in our curriculum and don't have a 200-year history of why we can't make a change. So I kind of like your idea, and I'm going to think about it, but if you want to give me any specifics later, that'd be great.
Absolutely. I'll reach out to you further about this. I think it's a great opportunity for a lot of students here. We have really, really passionate members in our organization and in the area. Yeah. Thank you so much for that opportunity.
Okay. Well, thank you for co-creation is one of our mantras.
Yeah.
We co-create with students. The care I talked about is co-created with patients. We consult our membership frequently when we're thinking about new programs or changes. We always ask patients what they think. So it's all about teamwork and who's on the team and who wants to participate.
Absolutely.
Other things, I don't know. How long am I supposed to be here? But I'm happy to stay as long as you have questions, comments. Can talk for as long as you want.
I'm just so excited for the opportunity to get to work with you as well. I mean, for everybody here, to be honest. Like we talked to, I was talking to Mr. Scott Towler originally. So it was really funny how we reached out to Kaiser Permanente. I DM'd the Instagram page asking them, hey, could we have one of the doctors? Could we meet with, I think they put a quote by you on the Instagram page. And I was like, I love the quote. So I was like, can we meet with this doctor? And they said, yeah, sure. I was like, what? Really? Said,
Okay.
yeah, we'll forward you, send us your email. And this whole process has just been amazing. It's, it's.
All right. You'll have to let me know the quote I said, because I don't remember it.
Yeah. Yeah. It's really exciting. We see, at least I personally on my Instagram, like that's the best way to engage with like young people our age. Like I just see it like almost at least 3 times a week. I see like another like an ad or like I see it all over. So Kaiser Permanente Medical School is like really like becoming really well known. and a lot of students are really interested in it.
We had a lot of applicants last year, and we're getting a lot this year.
Mhm.
And I like to think it's the reputation of the Kaiser that it's a different kind of education. I believe the free tuition does not hurt us at all, and it's a good deal.
No, but absolutely. Like, yeah, I think a lot of the education system is just really aligns with what we've been doing with AMPC. Like, I saw that you guys had like this 3D, not 3D, like these Microsoft HoloLens
Yeah,
devices.
right, for our anatomy, yeah.
We purchased one for our organization as well.
Our anatomy is really cool.
Cool.
I was trained at UCSF doing traditional cadaver dissection. Took a whole year, and now the amount of detail, and I think it's a much better way to learn. But if you ever come out here and visit our anatomy lab, it's not only that, there's all sorts of computer graphics and imaging correlations with gross anatomy and radiology anatomy correlations. It's in the HoloLens, it's pretty slick, and a lot of this stuff sits on students' laptops so they can take it home with them and not have to sit in the anatomy lab all day long. I see Xavier has a question, or was your hand up from before?
No, yeah, I had another question, and I may sound like a stalker because I got this from the page as well. But I just have to oh my gosh. But I read about the KP SureNet, the program to help decrease like missed or delayed diagnoses. And I was just wondering, like, how did that program come? Like, not how it came about, but how does that work? And also, are there any diagnoses that it's particularly you see, I guess, the best results in?
Okay, so I give like an hour talk on this. I've given at the National Patient Safety Foundation. This started probably about 10 years ago, and we realized we had a hole in our system. If you do 10 million lab tests, and you're 99.99% good at following them up, there's still stuff that falls through the cracks. And nobody had, I mean, this is a well-described problem in the medical literature. What we did is we actually saw some of this came from our malpractice data, which is all integrated in our system. Another problem where other places don't necessarily aggregate their malpractice data, but it's really hard to defend a suit where a lab test comes back, it's abnormal, doesn't get followed up on, and you go into court. So you might as well just write the check over. And it started that way. And we realized we had a high test for prostate cancer, didn't get followed up. We don't know why it actually didn't get followed up, because frequently it's not documented into the chart to the point about the electronic medical record. But, you know, in retrospect, everybody makes their claim they didn't know. And we realized we could electronically scan the system and look for abnormal lab tests that don't get followed up if we can define what a follow-up looks like. And so I started working on this with a few other folks, and we said, okay, we'll define for this particular test, a follow-up might be a urology appointment or an oncology appointment. And so we could look through our system and find a bunch of abnormal tests that didn't have follow-up as we defined it. And we defined it in a way that we could easily measure it. This all gets back to the electronic record issue. And how do you capture data, and if you're integrated? So we started with one disease, said, wow, this is slick. We found a bunch of prostate cancers that otherwise would have been missed. Stopped our malpractice claim problem a decade ago, and did the same thing. We've got about 35 of these programs now. I've published on it. Brigham in Boston, Brigham Women's Hospital has copied this. We've got a few other places I'm trying to spread it to. I don't know why this is so hard, but you basically just need a way to surveil your population for abnormalities that aren't followed up and fix them. It works best on diseases that are slow moving. So if you have a month delay, it's not so terrible. You're trying to avoid a 2-year delay. So it's not good for inpatient hospital tests, but it's great for slow growing cancers and slow moving other diseases. And that's predominantly what we use it for. It's been written up in a monograph on diagnostic errors that the Institute of Medicine put out. And I'm working on some grants to spread this to other facilities that aren't integrated like Kaiser, so their data systems are fragmented. And the question is, can a non-integrated delivery system do the same thing? And I think it can, but that's what we're going to try and improve. So I hope I answered your question. I mean, to me, what I loved about my job is I could find a problem and actually fix it sometimes, not always, and make a huge difference. And this was an innovative program. It won some internal innovation awards. It's a great use of electronic medical records.
No, yeah, thank you. That definitely answered the question. I just, to understand why other facilities wouldn't want to utilize that tool. It kind of reminds me of what you said at the beginning, when different findings and research findings take about 17 years to get implemented. So that just reminds me of that a little bit, how other facilities wouldn't want to use that or questioning using it.
I mean, the barrier, it gets back to systems, but I speak at a meeting, doctors may say, wow, this sounds really good. I'd love to do this, but they can't just implement it in their office. You've got to get a team together of IT and medical informaticists and physicians of different specialties and nurses and other folks to actually make the thing go. And so whenever you have more than one department needed, the speed at which things happen dramatically slows down. This is why I can't emphasize enough not only being patient-centered, but team-centered, and teamwork is key. That to me is why this is a hard one to implement. Other comments?
I guess I have one, if I could ask, I'm sorry, I feel like I've asked a lot of questions already. Related to patients' role in healthcare, I know that with the US, we, like our healthcare system, it's like the patient reaches out to the doctor reaches out to the patient over and over, so to get like the information to the patient. But like in other countries like China, where I used to live, and other countries as well, it's more of responsibility is placed on the patient to collect these supplies. And I know that you were discussing with how being more transparent with the records and everything like that sort. How do you think that we in the US need to change the role of patients in their own healthcare, and how we've kind of made it so that it's all on the physician side and there's not as much what the patients can do, I guess? Because we see, I think as you said, like, a lot of patients don't actually follow up with the programs that they should be following.
Right. So, and that's interesting because like the example I gave with the prostate tests not getting followed up, we suspect at least a large proportion of the time I was a patient that didn't follow up, but nothing gets documented that way necessarily. I think in reality, the patients are responsible for their care. It's just we don't explicitly state so, but you can't make patients do stuff. And so it's the way we've grown up medical care, where the doctor's this all-knowing, all-wise being that is responsible for everything. If you go to a teamwork model that I'm talking about with the patient part of the team, I think you look at it very differently, and why it grew up the way it did, I think had to do with just a crazy culture of too much, I don't want to say too much respect for doctors, because being a doctor, I like respect, but it's misplaced, and I think this is an educational issue that needs to be talked about more. There are a lot of patient advocacy groups trying to do this. I think making medical records transparent is a key step. The internet is another key thing, as patients can look up all kinds of medical information on the internet. They can be more empowered to take care of themselves. And we have to be a little careful because there's a lot of misinformation. But 40 years ago, medical information was this mysterious thing patients had no access to. And with changes in technology, it's the opportunity to re-educate people and give them, they've always had the power to take care of themselves, but maybe give them the tools to take care of themselves. It's not only better care, it's actually cheaper. So I don't have the magic. There's the bullet. This is for the next generation of medical students. But I think directionally, it's how we interact and how transparent we are and how much we encourage patient participation.
Thank you.
All right. Well, I've enjoyed talking. This is fun for me, actually, by the way. So thanks for inviting me. I normally don't talk to, most of the lectures I give are to other physicians, and this is kind of fun for me. So thank you, and appreciate the opportunity.
And thank you so much. We are so excited to just continue working with you, and your lecture was amazing. Like I was really excited for it. I mean, everyone was excited. Like we told everybody in our group, like in our group meeting, we emphasized it so much. Like we just wanted everyone to like get to hear it.
Okay, well, good luck to y'all.
Thank you.
Bye.
Thank you.
Take care. Well, thank you everyone for coming. I'm tired.
Sorry, like there's so much going on right now. Thank you so much for coming, for attending this event, and we're very hopeful to be collaborating with Dr. Kanter soon. So if we come up with any ideas and after we meet with him, we'll definitely let you know, and that should be very, very fascinating. Yeah.
Sounds good, guys. This is how it's done. See you.
Bye.